Please be seated. Please be seated. Thank you.
Okay, our president, Stu Kohn, is going to welcome you. Thank you.
I want to thank everyone for being here tonight. My name is Stu Kohn. I'm the president of the Howard County Citizens Association. We have been celebrating our 64th year in operation as an organization. We're very proud of that, and we appreciate all the support that we've had over the years. I know many of you are probably a lot less than 64 years old, but we can't help that. Now, Howard County Citizens Association, the acronym is, as you all know, is HCCA. Many people think that HCCA stands for Howard County Complainers Association. Oh, see, the legislators know that. Deb, is that true? Yes. However, some people, including myself, think it's the Howard County Complimentary Association. And I want to compliment all of you for being here tonight. I also want to especially compliment our legislators for being here. Taking the time out of their day to be with us is absolutely extraordinary. And we have a guest tonight that will be introduced in a few moments. And I just want to say that the good news is I won't be standing here in front of you the rest of the night. I know you're all probably pleased with that. And because we have Lisa Markovitz, who I have to say is our vice president, and Lisa Markovitz has been an activist for many years. I have nothing but great admiration for her. She has been a tremendous person in this regard. In fact, that she's put all this together today. She did most of the work in having this assembly tonight. And she also is a tremendous writer in that she writes for the Business Monthly. She does an editorial, a commentary, and she's probably, as far as I'm concerned, I'm not her agent, but she is probably one of the greatest writers I've ever witnessed in my life, and I cannot believe how quickly she puts the contents together. Absolutely beyond belief. So on that note, I just want to say how much I appreciate everybody being here again. I appreciate our board. Our board is absolutely done a wonderful job. They're extremely dedicated. Volunteers don't get paid, but we like to be complimentary and also do things that are beneficial, we hope, for the county. So on that note, Lisa, please take over. Thank you.
Thank you, Stu, for all those kind words and for all the work you've done for HCCA and your other organizations that are lucky to have you helping them over the years. I'm going to reiterate a thank you to all of our attendees and our esteemed guests and our keynote speaker, Meghan McClelland, SVP and Chief Operating Officer of the Maryland Hospital Association is here. She'll be making a presentation shortly. Our legislators that are here, Maryland Delegates Jessica Feldmark and Chao are here, and Councilmember Deb Jung is here. We had some others who originally were going to come but expressed their regrets of having some other family events to attend and aren't here. If you're expecting them from the Eventbrite, just wanted to explain. So thank you again. Thank you to attendees who are current and former elected officials who are attending tonight. I want to really thank you all so much. Former Delegate and County Executive Liz Bobo is here. Thank you for being here. And Lloyd Knowles, former County Council member. Thank you for coming. Yay! Hi, thanks for coming, Lloyd. Be a little louder. Thank you so much. I will be louder. Thank you. We have a candidate for Board of Ed, Andrea Chambly, who is also here tonight. So, Chambly, thank you. Thank you so much. Pardon me? Oh, Jenny Thompson. Thank you so much. Jenny Thomas. Thank you. Thank you for being here. Thank you all. There's so many familiar faces here tonight. It's so nice to see. It's also nice to see some new faces, so that's great. My name is Lisa Markovitz. I'm the Vice President of HCCA, and I also have some cards back there for the People's Voice. I'm the president there. It's a civic and political organization that does a lot of work in the county, has civic coalition, but not political, with HCCA. I'd like to thank our board, President Stu Kohn. I'm the vice president, our treasurer, J.D. Smith, our secretary, Alan Schneider, our directors, Brian England, Howard Johnson, Paul Verchinski, non-voting members, Jervis Jordan, and Susan Garber. And I would also like to thank Stu's wife, Bev, and my husband, Paul, for all the work that they do and help with these meetings and other things. So thank you for that. We have a couple little housekeeping matters to stay in adherence to our bylaws for our annual meeting this evening, and so we'll try to wrap those up quickly. The board that I just mentioned, we did not have requests to have contested re-election of our board, so I would like to just have the minutes reflect that we are re-electing our board, this slate that I called out, and move that they are re-elected. Do I have a second? And all those in favor of re-electing our board? Aye. Any opposed? Good, thank you, that's done. So HCCA, as Stu mentioned, is 63 years old. We're very proud of our history of bringing voices together on county issues with emphasis on environmental and historic preservation, infrastructure, government transparency, educational and land use issues. Please see our site, howardcountyyhcca.org, for our many accomplishments and county activities and opportunities for input. We're going into a new membership dues round, so thank you to our members. I want to point out that there are membership forms in the back left and at the front where you came in, and there are QR codes to be new or renewing members, or physical forms if you'd like to take those, and we really appreciate your support, and donations as well, right, are always welcome. So anyway, thank you again for being here. Now, typically, HCCA at our annual meeting give out awards that we call Advocates of the Year Award. But this year we decided to do something a little different, and we decided to do a $200 donation to the Columbia Community Care, and thank April Lee, who runs the local food pantry there, and thank them so very much for the excellent work they do in the community feeding the needy. So we will be sending that on. And I want to just tell you a few little things. Please watch the cords. They're pretty much against the sides. Please watch the cameras. We are recording this event. We will be publishing that video shortly after. Please silence all your phones at this time if you haven't already. I'd like to also thank Brent Lovelace, who is helping with all of our recording here. Thank you so much. And without too much further ado, I am pleased to present our keynote speaker. And when she is finished, I'll come back to the podium and introduce our legislative desk. Again, please silence your phones, watch out for the cameras, and we are happy to have Ms. McClelland, who is, again, the SVP and COO of the Maryland Hospital Association. Thank you, Megan.
So thank you for having me tonight. Can everybody hear me okay? It's not on?
Oh, you know what? Let me just make a little announcement about the mics. The mics are always on.
Yeah.
If you push it, you're muting it. So if you push it again, then you're unmuting it.
Oh, I think it's on. Can you hear me now?
Why don't you hand that to me?
I'm sorry.
Don't worry about it. I forgot to say.
And I've already messed it up.
That's all right. I forgot to say.
I
There
also
you
have
go.
a very
Hello. There you go. No problem. So for everyone else who might be up here later, the mics are on, and they're always on. If you hit it, you will mute it. So if it's not on, you just need to hit it again. Not real long, just a quick press. If you press a long time, it'll turn it off. So don't get frustrated and hold it a long time. Just a quick press will turn it off, and a quick press will unmute it. So thank you so much.
Thank you, Lisa. Sorry, I don't follow directions well all the time. So I'm very happy to be here tonight. Thank you for having us out. I'll get into a little bit of my presentation in a moment, but I do want to thank Lisa and the Howard County Citizens Association for having us come out and share a little bit about what our hospitals, specifically here in Howard County, are doing. And I hope to have a real dialogue with you all. But first, it seems like we have a lot of esteemed guests here. I'd like to thank Delegate Feldmark and Wu for being here. So I look forward to hearing your panel later. and then all the former board councils. But it really touched my heart to hear about what you all did with the Columbia Community Care and giving those dollars to that. You'll hear through my presentation, hospitals can't do this alone. Healthy hospitals means healthy communities, and to hear that we're finding ways to create food insecurity and help people through those issues is really heartwarming to us, because that stops people from having healthcare needs that land them in the hospital. Nobody wants to come to our facilities. Most of the time when you end up there, it's probably one of the worst days of your life, and we're trying to make sure that we're doing things to keep you out of the hospitals so that we can make sure that you're the healthiest you can be. So thank you. And I also want to thank all of you for here. It's really a pleasure to speak to you. Community leaders are so integral to the health and wellness of our, not only Howard County, but all of Maryland. And so for having people engaged in this work with us is nothing more than spectacular to the Hospital Association. And I wanted to say thank you on behalf of our new president and CEO at the Maryland Hospital Association, former senator and delegate at one point, Melanie Griffin. She was the former finance chair for the Senate committee there, and she's really hit the ground running in the last 6 months and is excited to work with all of you here in Howard County. Additionally, we've been meeting with the county executive, Calvin Ball, and his team to forge deeper partnerships between the county, MHA, and the hospital, including Howard County General, I got it already wrong, Johns Hopkins Howard County Hospital, Shepherd Pratt, Chase Brexton, and other. And we are working to try to develop a pilot right now on how we might be able to help advance the Howard County health initiatives, as well as the things that we're looking to do within the hospital field. So just thank you for having us out here today. I'm going to do a little bit of MHA, but I won't overdo it for you all before we get into the issues that are probably more important to you. But the Maryland Hospital Association serves on behalf of all the hospitals in Maryland, and we really are trying to create collective action to shape policies, practices, finances, and others to be able to move forward with advancing the health of all Marylanders. We serve over 60 member hospitals. You'll see all the logos here in the state of Maryland, which also includes caring for over 24 Maryland jurisdictions, including Howard County. And our acute care hospitals, just so you all have a sense, it's different in Maryland than it is in other states. In other states, you have a lot of for-profit hospitals, which means you get a little bit of different care than what you do when you do in Maryland. All of our hospitals in the state of Maryland are nonprofit hospitals, and they provide over $2 billion in direct support to their communities every year. And these dollars really go to not hospital-related issues. They're related to education, prevention, transportation, food, clothing, and other critical supports. So we're really working towards trying to, like I said earlier, keep people not having to come into the hospital, and then when they get there, giving them the supports they need when they get home. And that's even as much as getting some sort of transport to get them back to their home or the next facility they need to go to. Additionally, and I just want to apologize, I'm sitting. I just want to be able to look at you while I'm speaking, so I won't have the laptop in front of me, but otherwise I'd be standing. We're really the safety net hospitals in the state of Maryland. You all have access, and sometimes not as great as access you want, to community services, but oftentimes when things don't go right or somebody's not able to get that access, you come to the hospitals, and the hospitals are there to care for you regardless of your ability to pay, and create access and stability in the communities. And so they provide over over $850 million in uncompensated care. So these are for individuals who cannot pay for hospital care that the hospitals are providing in the community, and almost $2.5 million every day in the state of Maryland. And this is not just weekdays, right? People get sick when they get sick. So this is 365, 24/7 every day in the communities that they're doing that. And I know we're going to talk a lot about EDs, wait times today, and I know it's nothing that any of us feel happy about, but I want to give you a sense of kind of the mass of what we're working on. In the state of Maryland, we see, somehow I moved back or forward too quickly. What did I do here? 1.7 million emergency patients a year, which is almost the population of West Virginia. That means almost 5,000 patients are coming through the emergency departments in Maryland's hospitals every day. So these are people, like I said, at the worst day of their life, coming into the hospitals trying to get the care that they need. We're also economic drivers in most of our communities. We are the largest employers. We employ over 100,000 people in the state of Maryland, and that creates other jobs, which is almost another 115,000 people on top of that. So these are big parts of your community. I'm sure there's people in here who have loved ones, friends, family members that are working in Maryland's hospitals every day. And these are the most committed people I have ever seen. They come up, as we say, boot up and show up to care for patients in Maryland's hospitals, even in some of the harder conditions. So we're excited to be here and to care for you all. And I want to just tell you a little bit more about how the Maryland system's a little bit different than the rest of the country. And then I really want to get into the issues you all are talking about. So we have this weird thing called the Maryland model here in Maryland. We pay hospitals and health providers in Maryland different than every other state in the country. And in fact, our model is so successful that the federal government has now decided they want to copy it and put it in other states. And I just wanted to give you a little bit of sense of what that means for you all. So when you go to a Maryland hospital, it's different than the other states. If you look at the green bars on this, typically if you have commercial health insurance, Blue Cross, Blue Shield, United, Aetna, they pay a whole lot more for the hospital services they're given. And that means you all pay a whole lot more if you have those because they are charging the patients differently on that. In Maryland, we said we don't want that. We want everybody to be able to have access to care for the same cost. And so we had our annual meeting Monday and Tuesday of this week, and we had the pleasure of giving Senator Ben Cardin a Lifetime Achievement Award at our meeting. And it was really affirming to hear Senator Cardin's words. He said, if you live in any other state other than Maryland, you will see a 2- and 3-tiered care where not all hospitals are equal. For-profit hospitals set up and expand in wealthier communities where they're likely to get more commercial payers. And then you have all the people who are on Medicare and Medicaid that end up in hospitals that are not well-resourced and well-funded and that they don't get the same level of care. This burdens the patients, it worsens outcomes, and our system is not set up that way. It's set up to have equal access and fair outcomes for everybody. And I know I'm probably already losing you guys, so I'll move quickly, but I just want to keep giving you a sense of what we do here differently. Our hospitals actually work under a fixed budget. So other states, if you come in, they get paid for each patient that comes in. In Maryland, we have a global budget that says we're incentivized to keep you healthy so you don't need to end up in the hospital. So we want to make sure that you don't need us unless you really need us. And over the last 10 years, we've saved over $2.2 billion in healthcare costs, which is to the whole system, but that also means out-of-pocket costs for patients, deductibles, that we are able to keep patients from having to be admitted to our hospitals when they can do other things. But the coolest part of our system are these 3 things. The Maryland model is built on equity, community, and value. So we'll start with equity. Marylanders get great healthcare no matter where you live, who you are, or the income that you have. In our payment system, everyone pays the same and everyone's welcome at the nearest hospital. In terms of community, Maryland is the only state in the country where hospitals are accountable for the health of their communities, not just their bottom lines. Essentially, they try to keep people out of the hospital. Hospital invest in outside their walls so people don't have to be brought into acute care. They focus on the health of the community. And I'm going to talk a little bit more closer. Okay, sorry, I'm so loud. I thought if I got too close. They collaborate more on their working with partners and with resources and with their neighbors. And then finally, value. We don't dictate prices. In other parts of the country, they can charge what they want to charge. We have a set budget to keep our communities healthy. And this allows us to focus on quality and value of care. But this is the part that's going to get to what you all are seeing in your own community. While equity, community, and value have a great foundation for the acute care hospital setting, we know it's not enough. We need to have a greater degree of partnership and collaboration. And we're looking to engage others to play more a proactive role. Now I think I'm getting feedback in the model, so that you all have the resources you need in the community. The hospitals cannot do it alone. So for having truly healthy communities, that relies much more on what we can provide, much more than what we can provide inside the hospital walls. This is strong primary care and preventive care, consistent and accessible chronic disease management, prenatal care, and with emergency care, having the community understand where to go and seek different types of care, and access. Not everybody in this community has the available access to primary care, specialists, behavioral health, and I'll hit on that a little bit more in a moment. Physicians, just even that we have a lot of people in our community who can't make it 9 to 5 to a physician's office. Do we have the available hours and those things available? And believe it or not, insurance coverage. We also need to look at things that we have now determined by the research that really affect your outcomes in life, and those are called social determinants of health. Do you have reliable transportation? Even if you come to the hospital and you have an event, and then we say you need to go see this doctor to do the things you need to do afterwards, if you don't have a car to get there, that won't happen again. You'll end up back in the hospital for needs that you don't need to have, but we could take care of you in the community. Nutritious foods, just time to have activity, physical activity. And then after you're done with the hospital, many of the people that leave our hospitals don't go home. Some do, but they don't have the care that they need at home, either from home health care or caregivers that are unable to be there when they need them to. But we have skilled nursing facilities that have limited access. There's rehabs that are not available. There's mental health services that are not available. The list goes on, and I won't bore you with it. The other piece of it is insurance coverage, and I want to like to thank our delegates and others in the legislature this year, because they did expand coverage this year, which is very important, and the Maryland Hospital Association backed that as well. And we have decreased the number of uninsured in half from 2007 from 13 to 6 to today. But there's still too many Marylanders that have high out-of-pocket costs and high deductibles that actually stop them from coming to get care because they don't think that they can afford it in those situations. So we're working with our legislators to ensure access to care and improve hospital throughput. So I'm going to get to the meat of it, which is probably more of what you guys want to do. And some of this is a little specific, but I'm going to try and make it more about your communities. So recently, we worked with the legislators through a General Assembly work group to create a study on ED wait times. I'm going to say it out loud. They are no good. We are one of the worst in the country on ED wait times in the state of Maryland. The hospitals don't like it. The community doesn't like it. The legislators don't like it. And so we need to really take this from a holistic support situation. It's a systematic issue that we need to tackle. And part of that's on the hospitals, part of that's on other parts of the system. And so we had a group of 28 members of the General Assembly, the smartest minds around us in the hospitals, the emergency management people, patient advocates, that came together and came up with a set of system recommendations that we can move forward with. Some of these I'm going to dive in a little bit deeper on because some of them get a little bit insurance-y and other things, policy wonky, but I want to make sure you guys understand. So one of the things we're trying to do is work with the payers. The hard part of moving people through the system is oftentimes, and I'm sure you've all seen this, they require prior authorizations to move you from the next place to the next place to the next place. And we're saying, hey, we have a system that we're already incentivized not to want to keep you in the hospital, to get you to where you want to go. Maybe we don't need all these prior auths in the way that other states need. So we're going to work with our legislators to really talk about, like, is this the system that works in Maryland, or is this the system that works for everybody else that doesn't do it our way? I'm sure you guys have heard a ton about the healthcare workforce. COVID decimated us. We have an opportunity to bring more people in, but we're looking to have help to be able to do that. It's hard in our hospitals right now. The incidents of violence have increased exponentially. Nurses are getting attacked. They're trying to leave the workforce. Burnout is happening. And so we're looking at ways to retain the workforce, but also grow it through our communities. And I'll talk about that a little bit more. Some of our most vulnerable patients are getting stuck in our EDs. There are people in our EDs that don't need to be there. They could be going home. They could be going to other places. However, they are juveniles that don't have a placement with their parents, so they were waiting for the state to take guardianship of it. There are people that don't have behavioral health beds. So we have people, what we call boarding in the ED, that no longer need services, but we have nowhere else to put them. And so we keep them in the ED to keep them as safe as possible, but it's not allowing for other people to take those beds that they need. So we're going to be working with the legislature, the judicial system in the state of Maryland to work on that guardianship process and how we can really move people from one way to the other. Our system in Maryland is really good, but we also have to look at it to see, are we creating enough capacity that allows us to serve the patients that we have in our community? So one of the things we asked was to say, take a look at our Maryland model and say, is there anything we need to enhance or update to be able to move more patients through our hospitals and allow for the capacities for the communities that are growing legitimately? We don't want volume in the hospital for no reason, but if your community is growing, how can we advance that? And then really being able to share data across a lot of different groups. These go into more detail. I am not going to read all these to you because it would bore you, but I really want to touch base on behavioral health here in a moment. We really need more behavioral health services in the state of Maryland, and I know that the administration, the legislators, we all know that. So we have to work on that capacity building and having wraparound services. When we have a child that is left in our ED because the parents have no other hope, they don't know what else to do, it's heartbreaking. It's heartbreaking for that parent. It's heartbreaking for our staff. So we have to find ways to help these wraparound services get to those communities so that we can get those patients where they need to be. We're also looking for improved access to complex patients and this idea of hospital at home. So oftentimes people can go home, but if you don't have a caregiver that can help you with some of the basic services, then it's almost impossible for you to do that. If you need some oxygen or you need help going to the bathroom or you need help doing other things, how can we give more wraparound services to those communities so that they're able to do that? And we're really, and like I said, thank you to the legislators about expanding access to the uninsured and especially the undocumented members of our communities. If people are in our hospitals that are uninsured and undocumented and they really need to go to a skilled nursing facility, that facility won't take them because they don't have the insurance. So they stay in our hospitals taking a bed away from other folks. So we're looking at ways that we can create access that's more available to those folks as we move forward. There's a little bit of total health wonkiness on the slide. Like I said, there's some rules, federal rules, that we want to try to see if we can get changed. When it says explore modifications to CON, that's the certificate of need process. We want to work with our regulatory bodies and the legislature to say, maybe these ideas of how much capacity hospitals should have need to change so that we have more capacity to move people through those areas. So there's a lot to do here. The behavioral health crisis is beyond what most of us even understand, and it is the next pandemic. It is the pandemic that nobody's talking about right now. Sorry. Sometimes I hit the screen and then all of a sudden it moves. So the priority for us is behavioral health because we know it impacts our emergency departments. Annually, there are more than 1 million ED visits for mental health and substance abuse. We've seen an 8% rise in behavioral health ED visits over the last 8 years. We are actively engaged in legislation, both from the administration and the legislature, to improving the state's behavioral health infrastructure. There's also legislation to allow court-ordered outpatient for individuals with severe mental health illness who are not compliant with treatment and whose lack of compliance poses a potential danger to themselves and others. This has been passed in 47 other states, and we don't have it here in Maryland. So we're working actively to do that. But that alone won't do it. When we deinstitutionalized mental health services, many, many, many years ago, we did not create enough places for people to go. COVID has had a huge impact not only on our youth, which is a huge part of what we're seeing an uptick on, but even those in every generation. Mental health services is the unknown pandemic right now. And so we're going to work closely with the administration, with our legislators to make sure that we can expand access here, because they're in our EDs. They're in there not getting the care they need because we're just housing them, basically. They need to be in other facilities, and it's taking up beds for people that have acute care needs. And then our workforce. We are doing so much to create our workforce. We do not have enough healthcare providers. I'm going to talk about nurses a little bit here, but add techs, add environmental services people to clean the rooms before you come in and out of it. We just need a healthcare workforce that we can add. So 1 out of 8 every hospital nursing position is vacant in the state of Maryland. It's hard to run a hospital and serve patients when that's happening. And so we are working diligently to build the workforce in Maryland. And so we, through the hospital's collective work, have created a campaign called Join MD Health. We actually don't care if you come to work in our hospitals. We just want you to go work somewhere. If you work in a skilled nursing facility, that helps our hospitals. If you work in a primary care office, that helps our hospitals. And so we have a campaign, and I joke, they told me that if I see it, I'm not the right demographic. I'm too old. Thank you for telling me that, everybody. We're really hitting the younger folks in our communities to be able to say, come into this profession. They can go to this website and find out if they're a head, a hand, or a heart, which means you take this small little survey and it'll tell you if you're a heart, you might want to do this kind of thing in a hospital. If you're a head, you might want to go work in the finance department, like whatever way it works. And it leads you to any sort of hospital period of working on that stuff. So I think there's a lot of opportunity. We are very, very excited about how we move forward. But I want to hear from you all tonight, because we can only create great policy if we know what the concerns are in the community. We have an idea. We know what you all need. But we'd love to hear more, both from our legislators and then from you all, what we can do to help bring it forward. So with that, I will pause. Hopefully I didn't draw on too long and too many statistics for everybody, but I'm really I'm happy to stay, ask any question that you have, but I'll pass it back to Lisa to kind of MC from here. Thank you all.
Thank you, Megan. Thank you so much. Very informative. We hear so often that we have a lot of growth in the county, and we're worried about infrastructure issues, and especially, I'm sure that everyone in this room might have a frustrating tale about being in the ER for a lengthy period of time. And I have had several of those experiences myself. And you say to yourself, well, why can't they expand the hospital? Why can't they open a new hospital? We have more residents coming, growth, and how are we handling this? I only paid Stu a small amount to accolade me so well, but I do have a Business Monthly column, and I did address this topic recently, and so I have some printouts of that in the back left. And one of the things that I put in there was discussing what Megan had talked about, the certificate of need issue. The hospital cannot just expand. They could not just add a whole wing, even if they could afford it. Even if they wanted to, they can't. We voluntarily are part of the program that has an oversight committee and has state regulations that you have to prove that you need the expansion. And it's a lengthy process, and it's complicated. And when Megan talked about working with legislators, a lot of people in the community in Howard County want to know, how can we maybe speed up that process? I mean, that process led to us having an expansion in our behavioral health facilities recently that you've probably read about in the paper, an announcement from the county executive that there would be, I think it was about 22 more beds in our hospital for behavioral health purposes. When I was recently in the ER, you could tell that behavioral health issues were rampant there, and that will help a bit. We obviously want to see even more help, if at all possible. So I hope that our state folks can talk about that a little bit.
Lisa, can I add one thing
Yeah,
that
sure.
just struck me? One of the things we're working on with the hospital is, and if you haven't been there recently, you probably have not seen it, but it's come on in the last couple months. They've created a discharge suite at the hospital. And the idea related to this is oftentimes they can't move patients off the floor because they don't have transportation home. They need like a couple things, but they don't really need to be watched by the nurse anymore. So they've created a suite downstairs that allows the hospital to go there, and then they will work with that patient to get them transportation, to get them food, to get them and they reiterate like the needs that they have. Here's the prescriptions you need. And they have now upped that to be able to move 30 to 40 patients down to the discharge suite a day. That will make a huge impact to throughput on that in the long run. That's the area we're working with them on, because it's the idea that the social services in the community is really what they need, and that we can get them out of there. So in addition to creating those behavioral health beds, and I was there last week at the hospital, and it's really cool what they're gonna be putting in. It's about moving people through too. And so I just wanted to add that because I forgot to mention it. They're really doing it. Not every hospital in the state of Maryland is doing this kind of discharge suite idea, and they're kind of on the leading edge of that. So that will help a lot with ED wait times, because the quicker you can get people off the floor, you can get the people out of the ED back up onto the floor too.
Great, thank you. And we are also hearing that Shepherd Pratt is expanding as well, so that may help us a lot. I'm going to get to questions really soon. So just real quick, I'm going to have our legislators come and sit. Would you check that those mics are working? Like I said, if they're not, like tap on them like that, and you can tell. If they're not working, just a quick press on the gray button should get them working. I'm going to have our three legislative guests who are here tonight talk to you a little bit, introduce themselves, maybe talk about some things they're working on. And then before we start questions, I'm going to let them ask questions or have some discussions about our topic first. And then they will turn back to me when they're done, and I will go over our process for the rest of the evening and question and answer session. So thank you so much. So again, thank you to Delegates Feldmark and Wu and Councilmember Jung. If you would just like to take a turn and give us your thoughts. Thank you.
Sure. Good evening. Is that close enough? Am I good? Okay. Good evening, everyone. I'm Jessica Feldmark. It is my honor and privilege to represent District 12A in the House of Delegates, and I serve on the Ways and Means Committee, so we do not deal with healthcare policy, but it is something that, of course, is important to all of us, as it is such a critical need in our community. I wanted to start off this evening by highlighting 3 bills that we passed this session, and I think Meghan actually touched on a couple of them, but just given the topic of the evening, wanted to focus on them. One is dedicated funding for 988, and this is one that of the 3, this is the one I'm most familiar with because I happen to be the lead sponsor. But what we were able to do is establish dedicated funding for 988, which I'm going to ask for a quick show of hands. Who knows what 988 is? Okay, so we have some work to do on the public education and awareness side. So 988 is a relatively new national program for all of the states to be consistent in the number to call for suicide prevention and mental health crisis needs. So similar to 911, 988 is the number to call if you or someone you love needs immediate mental health crisis assistance. Or if you need help finding the appropriate care. I think that's one thing that's important to say is if you're questioning whether it's enough of a crisis, whether it's an urgent enough need, go ahead and call, and they can get you connected to the right services if it's not a matter of them actually providing service directly on that call. So this is a service where when you call, you actually reach a qualified mental health provider to deal with the crisis at hand. And if it's not a crisis that they can talk you through over the phone, if they need a crisis response team, they can dispatch a crisis response team. But this is really important for a couple of reasons. One, making sure that people get connected to the right kind of response. If someone has a mental health crisis, it's not necessarily a police or emergency services response that we need. A mental health crisis needs a mental health response, so that gets them to the care they need. It also is, and this is why, thank you very much, the Maryland Hospital Association was a strong supporter of the legislation, it also is a really critical piece of keeping folks out of the emergency room when that may not be where they need to go, right? But without an alternative, folks may end up going to the emergency room, and then they're part of the backup and extending the wait times, right? But we can totally avoid the emergency room in a very large percentage of those cases, right? And get people to a better service, a better response for their needs, and keep them out of the emergency room. So that's one. Another is the assisted outpatient treatment, which we don't have in place yet, but what we did this year was we approved establishing the assisted outpatient treatment. So this is for folks with chronic mental health needs who are sort of frequent emergency room visitors in and out of the hospital, can stabilize in the community, and then, stop taking meds, stop treatment, end up back in the hospital again, right? And it's an ongoing cycle. So currently, in terms of sort of enforcing treatment, it's the only opportunities available are for folks who are posing an immediate threat to themselves or others to be involuntarily committed to a hospital, right? But this allows for civil action to compel folks to stay in their outpatient treatment. And it's just an additional tool to help people stay in treatment so that they can stay out of the hospitals and out of the emergency room. It has been, and I'm sorry that Delegate Hill isn't here. She serves on the Health and Government Operations Committee, so dealt in great depth with this legislation. This has been a many years effort, and it took a lot of negotiation because it is a really delicate balance in terms of making sure people get the care that they need and making sure that we're respecting their rights as individuals, right? So it was a very complicated, very delicate negotiation, but after years of all the stakeholders working together, we did finally get it passed. So now local jurisdictions can establish assisted outpatient treatment programs. I think they have until next year to say whether or not they're going to establish their own, or if the local jurisdiction is not inclined to manage that themselves, then the Maryland Department of Health will establish a program for that jurisdiction. So again, this is about helping keep people out of the emergency room. And the third bill, which was a big success, and Meghan mentioned briefly, was the Access to Care Act. And this is legislation to allow undocumented immigrants to purchase, and let me say that again, purchase, spend their own money. There was a lot of misinformation about this bill as it was working through the legislature. This is not any kind of subsidy for care. This is simply allowing individuals who are undocumented to spend their money to buy health insurance through the Maryland Benefits Exchange. And so by letting people get health insurance, we are, well, first off, we're eliminating a big chunk of the $857 million a year in uncompensated care, right, which we all pay for through health insurance premiums. So we're eliminating that uncompensated care, but more importantly, or just as importantly, we're getting people better access to preventative health care, right? With health insurance, someone can see a primary care physician. They don't have to wait until they're sick and as a last resort, go to the emergency room, right? So again, this is about getting people the right kind of health care as opposed to emergency room health care, which is not only the most expensive to provide, but also part of this bigger problem of ongoing waits. And then in addition to the legislation we passed, we did also provide funding for the hospital's behavioral health unit expansion. I know the county has been very generous in funding for that project as well. So those are all, all pieces of the puzzle to try to decrease the load, the volume of people coming through our emergency departments. I feel like I've been talking for a while, so I am going to pause. There's plenty of other issues we dealt with. I wanted to keep it focused on the topic of the night. I will say in the back table, I do have copies of my end of session letter, kind of sharing some of the highlights from the legislative session. Some of you in the room may have already received a copy, but if you didn't and you want to check it out, that's a bit of a summary, and I'm happy to discuss any other topics once we get to Q&A. Thank you.
Thank you so much.
Good evening, everyone. It is a pleasure to see all of you. And thank you, Meghan, for that great presentation. Everybody here is very interested in knowing how are we going to solve our emergency room problems. And if you haven't waited there, well, let's hope you don't get sick, because that is what people are experiencing in Howard County. I know some of you have gone on a field trip with Dr. Ahmed, who is the head of our local hospital. Raise your hand if you went on that field trip. Oh, there are a lot of you here. Great. And I would ask you here in the audience, and those of you especially who went on this field trip, did you see or hear about the behavioral health issues that we have at our hospital? Yes? Yes, you did. And did Dr. Ahmed show you the area where he is planning to increase the number of beds in the behavioral health area to 22 beds? He did. Okay. And did he show you what his other plans were for increasing the number of discharge beds at the hospital so we wouldn't have to have a discharge room? Meghan, I know it's great that we have a discharge room, but it would be even better if we actually had a nicer, slightly nicer place to put those patients. So he talked to you about that as well. Okay, so here's what the county is doing. This year for the FY25 budget, we put aside $15 million for the hospital's emergency room expansion. That's a down payment on a $15 million contribution that we are going to make to the hospital to help expand it so that they can handle more patients in our emergency room. It is specified for the emergency room. But I do want to get back to certificate of need, okay? Oh, I see that little smile over there because that is an issue, and that is an issue on the state level. So $15 million we gave to this hospital to make sure that it will have the necessary money to help expand. That isn't actually what it costs. That was our contribution, the county's contribution. And I will tell you, I am pleased to have voted for that because I know that we have these problems. So I am happy to have made that particular yay during the course of our budget votes. But that's only half the cost All right, it's $30 million. And what the county is hoping and what the president of our hospital is hoping, Dr. Ahmed, is that $15 million will spur the commitment that we know that we need to get from Johns Hopkins to complete this process. Because we won't be able to complete it unless Johns Hopkins does their part. And Johns Hopkins won't do their part unless the county is doing what we agreed to do. So that was one of the big things that we accomplished this year. We also gave another $1 million just for the hospital's behavioral health unit expansion. And we invested $1 million in Shepherd Pratt. I don't know if any of you have ever seen the Shepherd Pratt. Oh my gosh, it is so beautiful. I would like to be committed there. If I ever had to be committed, that is where I want to go. It is the most beautiful grounds, and it is in the most gorgeous setting, and these great big windows. It is such a beautiful building, and it is in the middle of this really pristine sort of forested area. And we said, okay, we gave you $1 million last year in FY24. We're giving you $1 million this year in FY25. And in return, we are getting something that I consider a pretty big deal. 16 beds that are dedicated to Howard County residents. So if you have a behavioral health issue in Howard County and you go to that hospital, the hospital will immediately be able to take you to Shepherd Pratt if they cannot deal with your issues, or if there's already too many people in the emergency room and they need those extra beds for other people. So they can send you now over to Shepherd Pratt as a result of that contribution that we have made to expand the number of beds that they have over at Shepherd Pratt. Last year, we gave Shepherd Pratt $1 million, and we gave $500,000 to Turk House to aid in addiction recovery. And we gave $1 million to the hospital last year, too, but we realized that we needed to up the ante. So that is what we do for our hospital here to try and relieve the overcrowding in Johns Hopkins Howard County Medical Center. Did I get it right? Yes. All right. Okay. I will always call it Howard County General. I'm sorry. When you've lived here for 37 years, you don't change your ways. Yeah. So I think all of that is important. There's no doubt about it. Money is important in this particular instance. And we need to do everything that we can to support our hospital. But we also need some changes on the state level to make it a little easier to add those beds when we need to. So I hope that our two delegates here tonight and Meghan will talk a little more about the certificate of need and how we can address that issue when it comes to adding more beds at our hospitals.
Thank you, Deb.
Hello, good evening. My name is Chao, a delegate from District 9A, serving with Delegate Natalie Ziegler and Delegate Curtin Watterson and Senator Katie Hester from East and Western Howard County and West Montgomery County. This is my second year on the state delegate. I proposed 10 bills and 2 bills passed. One bill is really try to create a task force to get the county government, county council, board of education, and our state delegate come together to think about how we can address the school maintenance issue. We call about $1 billion budget deficit about the capital project. So we will work on that. I think we probably will convey our first meeting very soon. A second bill passed is about try to create more opportunity for our citizens about career and technology in our public school system. Make sure our students have choices in terms of their future career. And then there are many other bills we passed. I just don't really try to pick that up. So I'm talking about some bills for next year. I want to mention my director for public policy and Alan Schneider, and he's the secretary of HCCA as well. So if you have any questions, you can reach out to him. He has been a great resource for me and a great help. I truly appreciate that. I have some idea for next year bill. It's really based on what we hear and what we see. I think some bills about, for example, the superintendent buyout limit. So we had a situation in Howard County. We paid the superintendent like more than $1 million because the kind of she break out of the contract. Right? And then now Montgomery County is a similar situation. They paid the superintendent $1.4 million just to serve her less like remain a 3-year contract, which I feel is kind of ridiculous. I want to put a limit there. And right, I feel that, or probably in the future, every public office, if they break from the contract, there should be a limit for that buyout. Like 4 years kind of payment, that's really out of the conventional wisdom. Some other bills about like school, I'm going to propose like ban smartphone in school, in middle and elementary school. I think we heard a lot of discussions. And when I serve on the school board, we even talk about this. I just feel by banning the smartphone in school with maybe some restricted situations, and then it's really can liberate our educators, just educate to teach in classroom instead of discipline and take a lot of in and something else. Then another bill I try to propose is really think about how we fund our school system. We have MOE, maintenance of effort, which kind of we see now it's not enough. At the same time, our county funding keeps growing in many counties, not just Howard County. But the problem, when the county funding or revenue grows, but the percentage county spending in school system actually decreasing, not only in Howard County, but in Montgomery County and in many big counties. So the percentage the county spending in the school system, when they were high, they can get like 67%. Now we are lingering around 50%. With a $2 billion budget, 1% is that means $20 million. So think about $20 million, how much school can do. So I want to really put a floor there, like have a minimal, like the greater of a minimal between the MOE and maybe 50% of the county operating budget. And somehow I definitely will work with others, see what's a good number there. But we definitely were presenting something reasonable and will be sufficient to support our education system. And some other talk about affordable housing. I'm going to propose a bill talk about the waiver and the pay new. I think a lot of people have problem with that. I remember when I was on CA board, we talk about affordable housing promised by developers. Actually, they never build. At the same time, they pay a little bit of money to the county, so the county can build that affordable housing, which is very challenging to get it built. So instead, we need a mandated percentage. I would say that would be really help them have a good expectation what they expect when they are granted a permit, or from the residents or from the county, exactly how many affordable housing we're going to have, and by just a fixed number, maybe 15% percentage. I think the county made an effort some year ago, but didn't go through. I'm going to do it from state level. So.
You know you shouldn't do that. But you're preempting the county when you do that.
Yeah, I'm thinking about that. I have not proposed it, right? But I feel just help you guys, right? And help the community who really advocate for affordable housing. This will help them have a really reliable and expectable numbers of affordable housing when new buildings come up. And another one is really about I would say, for senior community about ADA compliance. I'm thinking about propose some regulation for senior housings, and even for new housing, they need to probably make the room or bathroom or something, right? Really ADA compliant. It's really for people who want to age in house, and that's really for convenient for them. Instead, when they need to rebuild that when they're getting older. I think that will help our aging home initiative. That probably I feel reasonable. I just don't know how the developer will respond to that. Yeah. That's all. Thank you.
Thank you so much to all of our guests. Really appreciate your knowledge, your experience, and your presentations. Please feel free to stand up or raise your hand if you want to give more input as we proceed. I'm going to be calling on people who signed up out front first, and I want to ask that everyone please try to keep your questions brief. I know that a lot of us have, like I said, some ER tales, but we want to prioritize the productive answer time of our guests. So if we could please refrain from going into stories or long introductions to questions, and please just be prepared to ask your question concisely as much as is possible. I'm going to call you Ginny as soon as we do our, we're going to do it. Yeah.
Is the audience welcome to ask questions about issues other than the hospital as well?
Yes,
okay,
thank you.
Because
Yeah.
I'm also prepared to answer questions
absolutely.
about legislation or the budget or any other matter that I may not be able to answer them, but I would welcome those questions.
Right, yes. So HCCA is going to start off with a question that is healthcare related, and then we will turn it over to you all, and like Deb Jung mentioned, you can go into other topics as much as you want, local, state, or otherwise, healthcare or otherwise. So thank you for that. So let's get things started. For the whole panel to respond if desired, but I guess mostly to you, Meghan, is that what is being done or proposed to being done to get more staffing or streamlined processes to get ER patients' medical needs, including pain management while waiting, addressed more quickly? I think that's probably goes to the heart of the matter of a lot of our experiences out here. Thank you.
Sure. So some things I didn't touch on to talk about more about the workforce. Telehealth's a lot of this, and we've also been working with the legislators on this and remote health. So you don't need to have a nurse monitoring certain patients every 15 minutes if you had some services where you can virtually monitor the patient, because a lot of times you're trying to make sure there's not a fall. You can read the machines that are checking their pulse and things like that. So we're really looking at new ways in which we can do our care teams so that we can use the virtual part of the world on that. Additionally, we are looking at how we can use nurse extenders in our hospitals. So you don't, for every need, have to have an RN. You can have an LPN, a licensed practical nurse. You can have a CNA, a certified nurse assistant. You can have other folks that can help do certain things like help somebody get to the restroom, help somebody get bathed, those type of things. So we're looking at new care models within the hospitals to really extend the ability to be able to use those folks. Another bill that passed in the General Assembly this year that also helps a lot is we're trying to remove regulatory issues to care teams as well. So there used to be two different types of certifications. So CNAs, certified nurses assistants, would work in hospitals, and GNAs, geriatric nursing assistants, would work in skilled nursing facilities. They have the same credentials. They do the same type of work. So what we did was reduce the burden so that those people could work both in the hospital, in the skilled nursing facilities, if they wanted to pick up some shifts here or pick some shifts up there. So we're really looking at new ways to create a workforce. They also passed the Pathways to Care Act, which allows us to be able to give funding to nursing students to be able to care for some of their life needs so that we get more people into nursing. So it's hard to go through school, especially if you don't have resources from your family or other support systems. This will give them additional funding so they can help pay for rent, pay for transportation to get to school, be able to take the internship or the clinical rotations because they can't work during those times. So we're doing a lot of different new inventive things to help with the workforce. Additionally, in terms of trying to get people through the hospital system more quickly, a lot of hospitals are creating new positions that help get people discharged more quickly when they're ready to go. So you all know somebody who's been in the hospital waiting for somebody to come and tell them when they can leave, right? Those are only certain times a day. There's only so many people. And so they're trying to create kind of positions that are around admission nurses, so get them from the ED to the floor, and discharge nurses that get them from the bed out of the hospital. So we have a workforce task force at the Maryland Hospital Association that brings together our nursing leaders, our HR leaders, our CEOs, all the different types of elements of the hospital to really tackle these type of issues. But ultimately, I think it's going to be bringing more people into the workforce. So we're also partnering with our colleges, our community colleges, to be able to figure out how we can create more clinical rotations. But we have an aging nursing workforce. And so to have trained nurses teach other nurses, it's hard to find all those resources. So it's not an insurmountable problem, but it's a big one. And we're working with all of our partners to do that. So I think those are some ways that we're trying to figure that out. And then you'll see, you're getting triaged in the ED right now in certain situations. They are trying to pull people back that have the absolute most critical acute care needs. But we're treating patients in the emergency department. So as some of the elected officials had said, we really need to look at CON. Opening emergency department beds is good, but it doesn't get you to the floor if you need to go to the floor. And so ultimately we need to look at what's the real access issue for each community. And we're working with our regulators to see how we can better assess that as we move forward.
Thank you so much. Do you want to?
Well, I just wanted to add briefly, I think, definitely wanted to highlight, and I'm glad Meghan mentioned it, the work we're doing with community colleges, because that workforce training is so important. And HCC actually has really strong partnerships and apprenticeship programs with Howard County Medical Center. The other thing two things I wanted to mention briefly. One is in the workforce issue, looking not just at the hospital workforce, but home healthcare workers as well, right? Because part of the issue with getting people discharged is making sure that they are discharged into a situation that works for them, right? And that may mean needing a home healthcare worker. And we did do legislation this year for home healthcare workers. That is a field and a sector that unfortunately has been very unfriendly to work in. And a lot of the companies and contractors who place home health care workers are not great employers. So we did some legislation to try to protect home health care workers and really make it an easier field for folks to stay in. So I think that's an important piece of the puzzle as well. And the other piece I wanted to mention, which I don't think has come up before, but in the context of certificate of need, at the hospital, there's the discharge beds we talked about, but another thing that they're working on is increasing the number of observation beds, right? Because observation beds do not require the certificate of need, and often when someone's waiting in the emergency room, it may be for observation to see if they need to be admitted, right? So, and again, this is not not going to solve anything because we're talking about another finite number of beds and it's sort of shifting the process a little bit. But those observation beds are a way to get people out of boarding in the emergency room, and we don't need the certificate of need approval for observation beds. So that's sort of, I think, the next piece that we're expecting to hear a funding request for.
Thank you.
And in terms of bringing in more people to this workforce, I just want you all to know that 26 years ago in 4 months, I gave birth to a child who graduated as a physician assistant 2 weeks ago. That is my contribution. Thank you very much. I appreciate it. Thank you. You're welcome.
So I see that Delegate Terri Hill has joined us. Thank you so much for being here. Delegate Hill, we were about to start our question and answer session, and even though this is a healthcare themed evening, we are going to open any other question issues up for our guests and members. And if you'd like to say some words, thank you. Could you push your mic? Thanks. Sorry, I think it's off.
I'm sorry for being late. I had a starting at 7:30, and I didn't know that we would be up here with our keynote. So I did not understand the instructions that were sent out.
Sorry about that. Thank you so much.
So I don't. I assume the question that was being discussed was the worker shortage issues.
Oh, the first question we started off with was really talking about what is on the mind of a lot of our audience here, which is concerns about infrastructure support and plans to help with staff shortages and ER wait times in our county and elsewhere.
So let me just add, and if I'm redundant, just hit me, Lisa. So I serve on the Health and Government Operations Committee. So many of the bills, if not most of the bills that Meghan was speaking of, come through our committee. And I think what you heard, or at least what I was hearing the last part, is we're spitballing a whole lot of stuff. We've got a problem that has a lot of tentacles. And there are issues, for example, as Delegate Feldmark talked about, with the pay we're giving direct care people. And even as we've moved to be a society and a community where we can have more people getting good quality care at home and fewer people being institutionalized, whether in a hospital, nursing care, nursing home setting, what have you, if we don't have the right healthcare workers to do that work and we don't pay them well enough to have them do that work, that's a problem. And that wraps back around to what we've been trying to do the last, 8 to 10 years in terms of raising the minimum wage, doing the things like Delegate Feldmark was referring to, which essentially says that direct care workers can no longer be contract employees. They have to be waged employees. And for many of our agencies, that really does create some issues and problems. And from some of our direct care workers, it does as well. But we think overall that it's the right direction to go into. The other issue that we really haven't addressed, we talk about things to incentivize people into going into healthcare, but we really don't talk about the fact is not everybody who can go into healthcare would be somebody who would want to go into healthcare, right? So there should be a way of matching that there are jobs available that are attractive and pay well, but that we also have people with the right disposition who choose those careers not because it pays well, but because it's actually the kind of work that they want to do. And I think the work that we do to really expose more people at younger ages to the field is really going to be a big part of that solution. The other thing, as we talk across, and certainly the nursing shortages and the direct care shortages are paramount. We also know that, say, in the last 10 to 15 years, as compared to 25 or 30 years ago, we have significantly fewer foreign healthcare workers in the nursing field. We obviously have a lot more physicians and providers in that, which has been very helpful. But there was a time, Meghan, maybe you can speak to that, where we had a significant number of really good, really qualified Filipino nurses that were at our hospitals. And because of the issues with visas and some of the things that different administrations have done, it's become really a lot harder to get people who want to come here to do the work to come here. So we're really working with, again, sort of our native workforce. Along those lines, did you mention at all some of the things we're trying to do for physicians to try to improve that?
The loan repayment programs and whatnot?
No, we had two other things that that we did this year that I think are critical.
Oh, the credentialing, yeah.
Okay. Because the healthcare workforce is all up and down, right? And there's some evidence that some of the issues with the long wait time in emergency rooms, and if you've ever been there, you get triaged quickly. They evaluate you, you get your blood test, the nurse comes by, but often what's making you wait and wait and wait is you got to wait for the physician to come by to do the discharge work, right? That obviously is a workforce dynamic that partially is about, what's the profit motive? So if you hire more physician's assistants and nurses to the ratio of physicians, then you've got that one or two physicians trying to see 20 or 30 people to get them discharged. So that's part of it, but the other part of it is there may not be enough. And in fact, we've done a lot of work in the last few years to try and have other people who are differently trained play the role of physicians. And whether that's nurse practitioners who now have full licensing capability, full prescribing capability, and can practice independent of physicians. And we also have physician assistants who've been pushing for similar things, came up with good legislation that we think threads that needle pretty well, takes away a lot of the requirements for them to work under a contract, but still having them act as what they're trained to be, which are physician extenders. So two of the things that we did to try and address this issue is, and I'm proud of this, I introduced and passed legislation this year to prohibit the use of non-compete clauses in healthcare contracts and in veterinary contracts. It was amended so that it only prohibits their use for licensed professionals who make up to, but not more than $350,000. Okay, but that's a lot of people. And if you make more than $350,000, they can use a non-compete, but it's limited to only 1 year. And the mile radius, I think, is 10 miles, 10 miles, which is a huge opportunity for people who have been providing care in the community, particularly nurses, particularly physicians, who then, for a variety of reasons, want to leave the practice they're in or want to leave the hospital they're in, and up till now have been prohibited from just joining another group or hanging their own shingle and have been forced to move out of the area. And I know over the years I've had any number of patients who've come to me to say, hey, Dr. So-and-so's disappeared. Why would they just disappear in the middle of the night? And a lot of times that's because Dr. So-and-so was prohibited from setting up a practice and may also have had a prohibition on sharing the plans of what they were doing with their patients. So the hospitals who fought this bill vehemently still have the ability, and as do large practices or small practices, to get clawback. So if they invest in a physician or a nurse or someone coming in, they can get that money back. They can still own the patient list. They can still do all these other things that help them to stay competitive. The bill also includes a look at what is the role of private investment, private equity, who are buying up all these practices. And is that really helping our healthcare situation and patient access, or is it harming us? So we'll be looking at those two things. The second thing was that I introduced a bill that has been sent to summer study, which would have created a shortened pathway for physicians who have been licensed and practicing for at least 5 years in another country and are living here to be licensed here. As it is now, if you're coming from another country, if you've been practicing, you have to repeat your residency. If you have a specialty, you have to repeat your fellowship. You can get a waiver for a year, but that is, it is not the best use of people who are trained. And as I said earlier, we've been doing everything we can to have people who are not trained as physicians play the role of physicians. So we'll see what that work group comes up, what that pathway looks like. But I think that has great potential for dealing with that part of the workforce issue, and think that it, and again, the non-compete also affects any licensed professional, including nurses, et cetera. So those are two pieces that I think will have hopefully a major impact in a very short period of time.
Thank you so much for that information. We're going to open up questions now. Jenny Thomas. First question, how do you turn this mic on? Thanks, Paul.
I blew the mic now. Okay, two quick questions. There's been a lot of discussion here tonight about the need for more observation beds. Have you solved the problem? Does it still exist where, say, a senior goes into the emergency room, goes into an observation bed, and then winds up in skilled level nursing or rehab? And by the way, Medicare more than likely will not pay for that, right? The second question, I'll give you both so that... Second issue has to do with the survey Meghan, is it Meghan? Yes. Talked about, which sounds exciting. When I was at UMBC, we got hired by Marty Wasserman to develop the Health Choice Program, which I think, unless this has changed, the Medicare program in Maryland is one of the best. So the hidden goal there, though, was after it got up and running, is to allow it to open up to government agencies, state, local, county, to have their employees come under that, and also the private sector. So eventually you had really, I know some people don't like this word, but sort of healthcare for all, using Medicaid as the basis, which solves your problem of how you actually pay for people going into hospitals, emergency rooms, et cetera. Is that even be on the table or being considered? Thank you.
So let me talk about the first one, which I'm trying to remember what it was. The 3-day stay rule. Yeah, I was going to go back to the slide. So there is this wonky federal rule that says that you have to be in the hospital for a certain amount of time before they will pay for skilled nursing facility care. So that's what we call the 3-day stay rule. It is ridiculous. We all agree that it's ridiculous. The hope I have on how we can solve that problem is we are moving forward. So I was talking to you about the Maryland model. We're actually at an inflection point with that right now to re-up with the new federal model that they've modeled off after Maryland. It's called AHEAD. And we are in negotiations with the federal government on how we move forward with that. One of the things we will be asking for as we move forward in that model is a waiver from the 3-day stay rule. Because if we're in an environment in Maryland where we're trying to keep people out of hospitals and put them in the right setting at the right level, it's kind of a ridiculous framework for us. So we're hoping in the new model, but right now we are prohibited, the federal government prohibits payment for those if you haven't been in the hospital for more than 3 days. The other piece on kind of the Medicare Advantage and those type of programs, it's an interesting thing in Maryland. We actually have less take up of Medicare Advantage, and it might be part of what our model does. So we're going to need to look at that. Which would put more people into these programs that allow them to have more wraparound services. So I think that's going to be one of the things that we can look at and talk about more so that people have more care around that. But also in the AHEAD model, Medicaid has many more things that they're going to ask to be implemented. And one of those is primary care services. So a more targeted metric for primary care services for Medicaid patients. So I think those policy decisions that should hopefully be made in the next year will have impact to the two things that you were just talking about as well. Yeah, Medicaid. That's what I'm saying. So it would expand more services there, but we have to work with the state.
Right. So
Yeah.
So Jenny, we have done, and you know, I bet you, because you're very up on this stuff. Since the ACA in Maryland, we have taken our uninsured percentage from about 14% to about 6%, and a significant part of that has been opening up Medicaid and making it more available to a lot of people. It's also been recreating a reinsurance market, and it has been creating subsidies for young people between the ages of 26 or above the age of 26 to be able to buy on the exchange. which is huge because that has allowed us to have more healthy people with health coverage, which lowers all of our premiums. It also gets them in the habit of preventive care when they're young and healthy. And we have now opened up Medicaid or access to health care on the exchange to people regardless of citizen status without subsidies, so they can go on and choose and buy insurance for themselves. But the Medicaid piece, making that more accessible and more available, has been a significant part of that as well. But 6% uninsured is a pretty good number, but we're aiming for 0.
Okay, next is Angie Boyder.
I just think I have 2 questions. Like most people, until you're really affected by these things, you don't really keep them. But I do know that. Sorry. Okay. I do know that one of the problems we have had in the past with emergency room crowding is the problem of people who need immediate care, but they don't need a hospital. But the hospital was told they could not refer them because they looked like they were denying them care. I mean, it would make a lot of sense for especially a patient with health insurance for you to say, hey, there's urgent care right down the street or a mile away that could handle your problem. Have we had any success in getting that barrier removed? Because that could be a biggie.
So unfortunately, this is another federal law. It's called EMTALA, that it requires hospitals to do an assessment of every patient that comes through their doors. We cannot deny care to any patient that comes in through our doors. So at a minimum, that workup has to be done, and then it requires a physician to discharge them, right? So we're working on the physician assistant side and things like that. So that is part of the issue. One of the things we ask the community to help us with this, and I fight this in my own family. I work in healthcare. I talk to them all the time. My daughter rolled her ankle the other week and my husband's like, let's take her to the emergency room. I'm like, no, let's go to the urgent care, but it's hard for people to understand the services that are available there that can do a lot for you. So we're continuing to look at funding just for the public awareness campaign, because we literally must work them up if they show up in the ED, whether or not they actually need to be there or not.
Yeah. I think you're talking about a big problem that actually goes 2 ways. And there are some structural things that we have talked about and should be working on, I think are working on, which is the other way is that people go to urgent care or patient first, and they're evaluated and they're said, this is what you have. You have to be treated at the hospital. And then they show up in the hospital, and too often the hospital says, well, we can't accept those labs. And I've seen that happen. And that's insane and ridiculous, but that's a structural problem. So what you're really saying is that the patient should be educated, and the facility should be talking and be able to understand. So patients should be educated that this is what you go for this and this. But once the workup's been done, there should be a soft handoff to the correct facility that goes 2 ways. That's, we've evaluated, we've triaged. And I mean, during my residency, so, 3-hour wait times were the norm back in, the 80s and 90s when I was training. Yeah, 3 hours, only 3 hours, right? But there were times when I would literally come out, if I was, we're down to the one surgical resident, and I come out at midnight and say to the folks in the ER, here's the deal, I'm the only surgeon on call. I'm going to call everybody up who looks like they need an x-ray. I'm going to send them for their x-ray. Some people have come in after you. They're going to be seen, but I'm going to quickly go through those people so we can get them out of here. If you have something that you can come back tomorrow, come back tomorrow, because I'm not going to get to see you for a few hours. Otherwise, sit here and know that I'll see you as soon as I can. And you'd all see people sort of shuffling and shuffling. But you have to treat the people who come, right? The EMTALA rules. But we can do a better job. I think there are ways that we can do a better job. And I think that is part of what the system and the legislature is looking at, although it is not the priority piece. But it's a two-way it's a two-way piece. People should be in the ER and they're not. And there is not, and people shouldn't be in the ER who are. And there is not the soft handoff where here come the labs, here comes the patient. They've already been evaluated. We've made a diagnosis. And we just need them to be seen, treated, or admitted. And it's gotten to the point that even attending physicians used to be able to call the ER and say, hey, I'm sending over Angie Boyder. She's got, cholecystitis. I want her started on antibiotics and admitted to the floor. When the floor is backed up, we can't even do that anymore. So it just makes it really hard.
And I would add, it's part of this connectedness of the technology that's a barrier for everybody too, because they're like, where's the labs? How the labs come? Like, there's sometimes even for skilled nursing facilities when we try to discharge out, it's like it's handwritten at times for certain facilities. I think we have a lot of opportunity on data and technology, but we have to figure out how to build the infrastructure to do that too. But I agree completely with Delegate Hill saying there's issues on both sides of that equation.
So the positive news is there are opportunities to do better.
Yes.
Thank you. Is Jervis Jordan still here? Jervis? No? Liz, Bobo, do you have a question? Yeah, thank you.
It's been a great program on, thank you, on healthcare. But I have one direct question on public safety based on, I think you can probably hear me. Based on an experience that we had in our home last week. So since Wood and I both retired for 10 years, we have been having pretty much every week, Monday through Friday, we get up and we have breakfast at home, and then we get the car and we drive up to Dunkin' Donuts. And we have a choice for coffee and to read the Washington Post. And we choose that village center intentionally. We don't want to go to Starbucks. I like my coffee better, but so last week we were there, and the staff who know us because I've been almost every day for coffee came and said that there had been an armed robbery attempt in the Dunkin' Donuts, and no one was harmed, but that was the case. So I will be calling into Chao, to our county executive, and also this is particularly for you guys. And I know you don't have an answer, but are we, what are we doing? Because I'm hearing more and more of this. And it's, I know there's no easy answer, but do we have anything in place to be more watchful? And then now I have one more thing. It was the day after that when we went up. For the first time ever, we saw two police officers on foot walking through that. And I think that probably makes a big difference when you have one out. So I tend to call out, I tend to call the county executive about this. But I just wanted to bring it up tonight.
Well, I think that probably a lot of people have been talking about or noticing or believing that there is an increase in crime. And there is an increase in petty crime, but there's actually a decrease in serious crime. So, but this is a serious crime. And that is a little unusual, believe it or not, in Howard County. We have a dashboard. So I'm just going to give you the general feel for this. Yes, it is. It is, yes. And we have a dashboard. We've created if you go to the Howard County Police website, you can see exactly how many crimes have been committed in your neighborhood. You've been to it, Fran? Yeah. It's really remarkable. And it'll give you, I hope, a feeling of safety, because most of you, I think, will be surprised, actually, at how little crime there is in comparison to what you see on Next Door Neighbor, and I see it too because I do look at it every weekend, okay, just to see what my community is thinking. And on social media and various other platforms, I look at all those. I see what people are saying. Most of them are really mad about the car break-ins, about the catalytic converter thefts, about the people who just decided to come by and smash their car window, about somebody who threw some paint on their house. And of course, we all know the ever present person who doesn't pick up after their dog. Okay. And those are the things but those are, those are the quality of life issues that people really care about. And one of the specifically now in response to your question, this year, yay, there was money in the budget to hire another 24 police officers and put them through the academy. And one of the reasons, as I discovered last night, actually at the police awards ceremony, that they were able to get so many people in so quickly to the academy is that there was a police officer. China Williams, by the way, is here tonight. She's my chief of staff. And I was thinking about this because, yes, thank you very much. China's fabulous. We love her. But Chris Williams, who is C. Williams as well as CC Williams, in case you ever need to get in touch with China, actually is a police officer in the Howard County Police. He got an award last night for something that he created to make it easier to get through the criminal background checks of people who are applying to become police officers. And it was one of the big reasons why we were able to get 24 people on board so quickly this year. So we are getting more police officers on. I brought this exact issue up to our Chief Durr, Greg Durr, and our county executive approximately 4 months ago when we were touring through all of the District 4 villages. Columbia villages. And I was told that we just didn't have enough police officers at that time to fully staff that little office in Harper's Choice. And I asked, just like you, Liz, can't we have more foot patrol? And can't you get foot patrols at certain times of the day when you know things might be happening? And we know when some of those times of the day are. So they're well aware of the issues, and I do hope that with the addition of this new 24 cadet police class, that they will feel like they have adequate staff in order to bring some of those people to some of the villages that could use those extra foot patrols. And one last thing, because we did talk about it today as well, and it was again with Chris Williams. Single C Williams, not CC Williams, right? And there were, and I hope there will be in the future, some plans afoot to build a new central police station somewhere in downtown Columbia. And I think that would also be a big help as well, because the plan is to have it be an inviting place, believe it or not, to allow, invite people to come in, to make sure that people understand the importance of police in helping the community. Well, actually, they're not going to stay. They wouldn't stay overnight there. That was another part of the conversation. They would be taken somewhere else. But yeah, okay. So that's the answer to that.
Thank you so much. Next is Diane Butler up here. Howard.
Hi. I think about 10 years ago, a bunch of us in this room sat on the hospital committee with Walt Atha, and we looked at some of the same problems that we're having now. I think you found some solutions to some of them. We were faced with a lot of the limitations, and I think what we did at the HCC for the nursing program, I think that came from that Walt Atha thing, and I think that was excellent. I think the things that you're doing and the bills that you're passing are excellent, so I want to thank you for that. Also, the Shepherd Pratt with the beds, that was an excellent thing also. I also sat on the APFO committee, and some other people in here sat on that committee for quite a while. And we looked at, again, the fact that this is the only hospital that we have in Howard County. So we have to remember one thing. The hospitals are for our critical care people. And we're still having the same issue that we had before. And at some point, we're going to have to address this fact that our beds, boarding anyone in the ED is just unacceptable for the rights of the citizens that need critical care help and critical care access. And this is the problem that we're still having. So we're going to have to look at, we've looked at certain different things that we can do, but we're still not looking at this bed problem. And we also did, I know we went back and we pushed the, that whole new bed system that we put in for the medical health center, the whole new center where when we changed the ER around, and that was beds that were set up for people that had the health problems, more of the mental health problems. We still have a problem with people that need to get medical care, and that's the one we're not dealing with. We cannot have beds that we're boarding people in. We've got to have dedicated beds that are open for people that need medical emergency care. This is an emergency room, and that's what we're looking for, and this is what we're still missing. And I understand with the Kohn program, as I call it, what kind of collective action are you looking to address, to combat the certificate of need? And also, we've got to understand that we're still doing the underinsured and the undocumented that are filling our beds instead of going to urgent care or other places. We did have, 10 years ago, we had a great big push for urgent care, and we advertised it and we put all that out. I think we need to do that again. But again, we are now a sanctuary county, so we've got that same issue again. We're still not fixing that problem, and that's the problem that a lot of people came here today about. And that they're talking about the absolute ridiculous wait times that we have back at the ER again. So that's what I want to know, is how we're going to get around Kohn and get things working to get dedicated beds that are not going to be boarding people. We should never be boarding people in the ER. We just shouldn't. I understand the Shepherd Pratt thing. That's a great idea. But those are the I think the nitty gritty that we have to look at. Thank you.
Diane, thank you for bringing up Kohn again, since I forgot to bring it back. So Megan.
Yeah. So maybe I'll start, and Delegate Hill, I'm sure, is very aware of some of this stuff as well. But one of the things we asked for as part of the recommendations for the ED work group, and that the legislature is moving forward with, is we asked the Maryland Healthcare Commission is the regulatory body that determines CON. Certificate of need. And so we asked for kind of an evaluation of that process. It has not been updated for a very long time. And so we've had hospitals, brand new hospitals that have opened, and the minute they open, they're filled to capacity, partly because they weren't able to get the CON that they thought they needed to begin with. So I think we have a positive step forward with that evaluation of the MHCC and their processes. It's outdated, and we just need to rethink it within context of not allowing hospitals to kind of go gangbusters and open up beds we don't actually need, but actually meet the needs of the communities. We have communities that are shrinking, and we have communities that are growing, and we have to be able to account for that. So since I've been with the association for 17 years, this is the first real step forward on trying to change the accountability that I've seen on the CON process in the last several years. So I'm thankful for all the legislators and elected officials' support on this. I don't know what the right answer is, but I know we are not evaluating it. And so we have to figure that out and have that done. So that's supposed to be done in the next year. Pardon? I can't speak to that.
So we tried to include an APFO provision for the hospitals, and I see a smile on Stu's face. Thank you very much, HCCA. They not only recommended it and have for many years now since I've been a legislator, but we did include it as an amendment to our general plan. I think that it's really important, Diane, and I don't think in a community that continues to grow, that one hospital is sufficient, and that a hospital need and what we are serving should be included as part of APFO. And there are other communities that have included their hospital needs as part of APFO. For those of you who don't know, APFO is the Adequate Public Facilities Ordinance, and it also says how many houses you can build or units you can build if the schools are overcrowded, depending on how many cars are on the streets, et cetera, et cetera. And in this instance, we would add the hospital. Well, there were two of us who voted for that amendment, and I was one of them. That means there were three of us who did not, and that means that it failed. So that amendment, even though we did try to get it as part of the general plan, we were not successful. But again, I want the people of HCCA to know how much we appreciated your support on that amendment. It was really important to us, and maybe someday.
Diane, I was just going to add one thing, and it's probably, I mean, you've been on the committees, you've been on the work group, so you understand it, but I want to make sure everyone understands that when you talk about beds, we're not talking about physical beds. We're talking about beds that are staffed, right? So that gets back to our staffing issues. We're always chasing something. So, we closed a number of beds some years ago, right? We used to have a pediatric ward. We didn't need pediatric wards because kids didn't need to be in hospitals anymore, so we closed those beds, and we took that down to a 8-unit pediatric unit. Then we basically took it down. Now we have a lot of young people who need psychiatric care. We don't have enough psychiatric beds. We're trying to address that, but we also don't have any pediatric beds, which might be able, if they're not filled with pediatric surgical patients, be able to at least hold some of these pediatric psychological patients with the right support and care so that they wouldn't be boarded in the ER while we're waiting for beds to open up in Maryland that don't, and many of those kids we're actually sending out to Delaware, right? We had a hospital in Laurel that closed. And the hospital that replaces it as a hospital, it's sort of a, ambulatory surgery kind of thing. And even their GYN and their OB cases are still not going there. The same thing happened up in Harford County. A hospital got closed, and University of Maryland opened up something that's not quite a hospital. So there's this substitution trying to catch up with sort of the changing face of healthcare that has to do with what used to be inpatient is now out. We've tried to keep caught up, as I said before, with the idea that more people can be treated at home, but you can't be treated at home if we don't have the right supports and payments and workers to do that. So it is a complex system, right? And the decisions that are made and implemented sometimes take 5 or 10 years for us to see the repercussions that were not anticipated, right? So we're closing beds we're trying to find more beds, having closed down a lot of beds, right? So we're kind of chasing a little bit. So and that's not to say it's not a problem. It's just to say that it's a little bit more complex than simply having a plan that says we need more beds. Because beds, we've got lots of, every hospital I know has an atrium with a piano in it, or something like that. So we've got plenty of space in our hospitals to make units.
Thank you so much. I'm going to interrupt here because someone said APFO, and that's all it takes. So Stu, Kohn, and I, Lisa Markovitz, we're on the last APFO task force, and they will soon be having a new one, I think maybe as soon as this fall, because the general plan was recently passed and updated. That's like a series of guidelines and goals that the county does in land use that was recently finished. And after that occurs, once every approximate 10 years, you have a review of the Adequate Public Facilities Ordinance, and a task force comes, and that is coming soon. And what we were told last time with regard to putting healthcare measurements into APFO, and what that means is right now we have measurements of school capacity that determine if there is a development that is planned that is near an overcapacity school. They have to wait like a little longer. It's a maximum of 4 years. And we do also know that the normal waiting time in the process of development in the county. It's about 3. And, I'm surprised the developers don't get mad at that instead, because it's really only an extra year for APFO. But they also get very concerned about putting other measurements in that would increase those wait times of proceeding with development when there's one of these measurements that trigger an extra wait. And the argument was that with healthcare, the hospital was a private institution and we couldn't control things with those data points. But as Councilmember Jung pointed out, over time now we are more and more appropriately funding the hospital. So that's really not the right response anymore. So when we get to the next APFO task force, they are going to clearly look at that again. And the new contention and concern kind of recently is that the deep desire to have more affordable housing in the county, that is a huge topic as to how to get it, how best to get it, how to make it more permanent, how to fund it, how to require it or not, whether there's low income, whether there's moderate income. There's a lot of things to consider, and some people just want to speed development because they think that is going to get more affordable housing. Some people want to do things differently, and so that's kind of the new contention and debate is, how do you pace infrastructure and how do you get enough growth and get more affordable housing. So I went off on a little tangent there because somebody said APFO, and that's all it takes with Lisa Markovitz. So thank you for listening. We will keep you apprised through our membership of all of these things that are coming in the county. So thank you. Next I have Christine Lobo. She's not here? Okay, Drew Roth.
I want to commend Ms. McClelland for your focus on equity and making sure that every part of Maryland has the same level of service from their nearby local hospital. I live in Elkridge. I live 25.
Our headquarters is in Elkridge, right on the door. Sorry, you had to say.
Yep. I live 25 minutes from Howard General Hospital. I live 15 minutes from St. Agnes. Our hospital is St. Agnes. St. Agnes is rated somewhat lower than Howard County Hospital. And when I hear that we're spending county money with taxes collected from the whole county, including Elkridge, and spending that on benefits that are only provided to part of the county, not including Elkridge, I get a little concerned that that's not equitable. So my question for you folks is, what are you doing to improve service at St. Agnes for Howard County citizens, your constituents who live in Elkridge, where St. Agnes is our hospital?
So, I would imagine that, there are people who go to Montgomery General and that there's people who go to, where Carroll? I think, now, wait a minute, Drew. Okay. We are in the center of the earth here in Howard County. I keep telling people that. We have 6 counties that border our little county. We are the smallest county in all of Maryland, and yet we have 6 other counties that border us. So to look at it from that perspective, there are going to be people who are going to go to different hospitals all around us. And I just want to tell you once again how much I love Elkridge, okay? Because I know that's important for you to hear it. All right? We love Elkridge. Should we do that as a
don't pay the same Howard County tax?
I know you're frustrated with that. I know. But I don't know that this is necessarily the issue that and I get that. But I do want to, as long as you guys are still here, I do want to make a note that Drew Roth, Paul Verchinski, and now Howard Johnson have all served on the BWI roundtable with me for 6 years. And speaking of Elkridge, because that's something you get more than anybody else, and that's plane noise. Yeah. So we are supposed to actually finally see some of what we hope will be a lessening of the noise on July 16th. So it's actually, we were supposed to get it on May 16th. They pushed it back 2 years, or 2 months, but it is coming. And I really want to thank these three gentlemen. They actually got on. Yes, thank you. Yep. Howard is now serving as chair of the BWI Roundtable. Drew did serve as chair of the BWI Roundtable. Paul hasn't been able to get off, even though he's tried. So he's still the alternate who really goes to all the meetings. Yeah. So I just wanted, given that they are part of this group, I really wanted to take this opportunity to thank them for all their hard work. July 16th, man, we are waiting. Angie.
Just follow up on that a little bit, because we have definitely noticed, and by the way, I really know you guys are
Hard, very hard.
great. We definitely noticed the so please don't let them, make things quieter by producing a problem for some other neighbor.
Yeah, that's, trust me, nothing that we have done has had any impact on that. Because if we notice anything, it won't happen until July 16th. So.
When you hear a sudden increase in noise, check the BWI website to see if there's a harm exposure, because that's often what it is.
Okay, thank you. Thank you. Next is Karen Emery.
Brian will give me one. Is it on? Okay. So I really appreciate the conversation tonight, especially around healthcare. I worked in the insurance business for many years, so I understand what a rabbit hole that is. But what I want to talk about is, I think it's tied to this issue, and I talked to Jessica about it a little bit earlier, is housing stability. I'm really concerned. We had a group of residents who worked really hard to do something with rent stabilization. And I think one of the issues with healthcare across the board is when you're sitting in the hospital, you think, how am I going to pay for this? I'm someone who has a decent job and I have health insurance. And last year I dislocated my hip, and as I lay in the hospital waiting to have an x-ray and figure out what was wrong, the things that crossed my mind was like, God, what is my deductible? I have a very high deductible. I have copays. It's not just straightforward. When I worked in the insurance industry, I did not have those, but now I work in a different company, so I have that kind of stuff. So this gets to my other comment. So I have a roof over my head. I have housing stability. I live in the house that I grew up in. I don't have to worry about my rent going up because it's got a mortgage. It's got a 30-year mortgage. The price stays the same. I have, that's rent stabilization right there. So last night at the Oakland Mills Village Board meeting, we had probably, I've had to guess, 50 to 75 residents come to our meeting to talk to us about what was going on at the Point, which used to be known as the High Tour Apartments. They overlook 29. And they have all kinds of issues going on there with their management company. Trash all over. They're infested with rodents. They're paying incredible amounts in rent. They have mold in their building. They have their water shut off. Their air conditioning doesn't work properly. We're about to have a weekend of very, very hot weather, and they've got a lot of elderly residents who are in there and people who have handicapped, who won't be able to necessarily leave to find a cooler environment. Their pool hasn't been open in several years, and the average, I heard several people comment that they're paying $2,000 or more a month in rent. And they're also being charged for internet services, so that they don't want. And if they try to opt out, the company somehow doesn't manage to take the fee off their bill, and then they go, and it takes them a while to get it resolved, and then they don't get a refund. These are expenses that are weighing these people down. And then on top of it, you talk about healthcare. So I really am interested when Chao is talking about affordable housing is what are we doing to make sure that we have housing stability? I guess that's what I'm looking for. I'm not looking for necessarily affordable housing, but just like people have somebody was talking about a floor before, I'm talking about a ceiling. Like, where are we capping this off? Because that also prevents people from getting health care. That prevents them from being healthy. If you've got a couple kids in an apartment and that apartment has mold, the water's shut off, that kind of stuff, you're already not in a healthy environment, and that's now contributing to the stress on our medical systems. So if anybody wants to address that, thank you.
I can start on the healthcare side of it. I don't know how you guys are dealing with the housing side, but we recently did a study, and housing is the number one predictive in Howard County, predictive of health outcomes. So it is a huge issue in how we deal with it, and it's tied very closely to socioeconomic and poverty and food instability. But it is a huge predictor of people's health outcomes. That's all I was going to add. But
Sure, thank you. So as I mentioned when we spoke briefly before the meeting got started, I think that's something that we do need to follow up with rental code enforcement, both on the physical side of things, which is the DILP area, and the sort of management side of things, which is more the Office of Consumer Protection. But I think the rent rates are a real problem. The increases that people are seeing and hearing that, $2,000 a month for really undesirable and unacceptable conditions is a problem. And I think that is in part due to the shortage of units, because where are people going to go, right? And so they're trapped, and that's a dynamic that landlords unfortunately can exploit and take advantage of, right? So, at the state level, we have worked on housing this session in terms of increasing the amount of affordable housing, eviction prevention controls, tenant protections, but none of that deals with the fundamental issue of simply enforcing. And we do have laws and regulations on the book to address those issues, but they have to be enforced, right? So I think that's a big piece of it. Another thing is making sure that, in one of the state bills we dealt with was eviction prevention, that a landlord cannot evict you if they're not in compliance with their rental license. Now, that doesn't address the needs, the immediate needs of cleaning up the mold and rodents and other issues that we're dealing with, but recognizing that that's one enforcement mechanism, right, is that they can't evict. But the county, Howard County, I'm talking about the legislation we did at the state level, but Howard County actually has, within Maryland, some of the stronger tenants' rights legislation, and the rental code is specific about conditions that have to be maintained in the unit. So I think that really sounds like an enforcement issue. So happy to work with you on that.
Karen, thanks for asking that question, and I appreciate all that everybody did who was part of that rent coalition. I thought it was very important and extremely well organized, and it was good to hear from all the different voices in Howard County. Rent control was a bill that County Executive Ball introduced in a housing package that he introduced last October, October 2023. And my personal feeling was that it was a great bill. It didn't go so far that I thought that all the landlords would go crazy, but it went far enough that I thought it could really help the people who really needed that kind of stability that you mentioned, Karen. Knowing what can't happen in the next year. they can't go more than X percent. And for those of you who weren't following it that closely, a little move took place on January 2nd, where 2 members of the county council refused to move the bill off the table. And there was a third council member who was out of town, myself, and another council member moved to take the bill off the table so that we could move it back on the table so it would live for another month and we would be able to pass the bill. And it died. That's right. You're absolutely right, Fran. Was it unbelievable? It was unbelievable. I was in shock. What you think? Really? Did you think that? Okay. It was shocking, and I tried to keep the look of shock off my face. I thought I did a pretty good job, personally. But yeah, so that was what happened to the bill the last time. I don't think that we are going to get another bill like that back in Howard County. So I'm afraid that rent control will not be one way in which we actually try and deal with the issues of too fast rising rents. And we are still hearing about it, Karen. I can guarantee you, China will tell you some of the incredible stories that we're hearing about from people who are getting $700 rent increases, per month. And it's just impossible to deal with. And some of those rent increases, I think, are landlords who are trying to rid themselves of low-income renters who, yes, are, yep. Insurance? Oh, well, yeah, there's always increased costs for landlords, and they certainly should be allowed to take those costs and pass along those costs to their renters, but insurance hasn't increased that much. So, yeah.
Karen, I think that's a great question. So one side I'm thinking about, unfortunately, Howard County is a very expensive county to live. So by rent, by purchasing a house, it's just not cheap, unfortunately, right? And then it's a market dynamics. And then I really don't have really think about any solution can address that. But at the same time, I'm thinking about another way to help those anti-eviction effort. I think about maybe the state actually can create a fund which is interest-free. And then when people face financial situation, they can withdraw from that fund, but they were asked to pay back. So I looked at the numbers, actually it's not big. It's around $3 million for the whole state. And for those people who are experiencing financial difficulty. I hope from that kind of effort will maybe help address those people who really in need. But for those others, I feel it's a really Chinese situation. It's a market economy. So I really don't know how to answer that.
Yeah, what I really see is doing the municipality issue is one, obviously that is very concerned about management companies, whether it's the owner or the management company not doing their jobs. And I think Delegate Feldmark hit it right. Those are issues that the AG's office is really interested in knowing about investing. They've had some real success on some of these larger groups on taking them to court and suing them. And, maybe we, from that standpoint, people need to be better informed, and maybe the state can do some PSAs or something, but other folks can do about 211 renters and what the AG office has and what different organizations are available. And they also need to know that you don't just get to not pay your rent because you're having a problem with the maintenance, right? And because people do that too, and they get into trouble behind that. But we really should be looking at who are the big players. Riverwatch is another example. I was touring there about a month ago, and that's, largely county-owned housing. and the company that's managing it is doing a piss poor job. And so we've got, and these are relatively new buildings that aren't being painted, aren't being maintained. It is horrible. So if we don't have the management companies or the landlords do the basic maintenance they're supposed to do, then it really does become a problem. And then they come back and say, well, our rent's not high enough for us to do the maintenance. It's a big issue. And I do think on some level, the more we do to enforce the laws about the quality that has to be maintained. And again, if we're not doing it on Riverwatch, which is our responsibility, it's really hard to get back and talk about the point. But we need to do better on both. And the AG's office is really taking the lead on a lot of that stuff.
Okay, thank you. Next is Fran Leprosti.
Would you say? I guess I did. All right, Dr. Bell. Can you hear me now? Yes. Okay. So I actually have 3 questions, but they're all very short. The first one, Delegate Wu, I chair the age-friendly housing work group, and I've developed minimal universal design based on what Prince George's County did. It's now with DILP. It's been sent there. It's been sitting there, and I'd be happy to share that with you. So I'll contact your office. I will.
Send it to all of us. Yeah, send it to all of us, please.
It's 2. One is full universal design, and the other one is minimal design. One of the things that the council did was they're exploring that 15% of affordable housing would have minimal universal design. Because if you think about it, if you want to stay in a house from beginning to end, in the beginning when you're building, reinforcing walls cost you $10. When you're trying to tear down a wall and put in grab bars, it costs you $1,000. I mean, there's some very minimal things that could be done in all of our housing in an aging population. We are aging no matter where you live. That would make houses more usable. And think about the people who have the double strollers, for heaven's sakes, trying to get in the house. So anyway, I will pass that along. The second thing is, one of the things I've read, and Jim over there will tell you about it, is that in healthcare in the future, because hospitals will not be able to take the increasing population, especially the elderly population, that more and more discharges will be at home because we have technology. It can monitor my heart rate, it can do this, there's all these things. Somebody can call me every 3 hours, did you take your medication? Even if I live alone, which a lot of older people do live alone. My question is, what are you doing to get everybody ready? What do I need? High speed? What do I need at my house to do this? Nobody is telling us how to get ready. That's the second. The third one is really for the, well, maybe I should just leave it at there with those 2. I'll talk to you later.
So I can start a little bit about Maryland has some of the lowest hospital at home health rates in the country. We have to do something different there. And part of it is having the right providers that are not getting taken advantage of to be in the homes. We also need to find ways to incentivize. We have people who want to be caregivers for those that are in their home, but they don't get paid to do that, right? So they have to stop working. They become part of the unemployed. So I think there's some areas we need to go there on. We had our annual meeting, as I was mentioning earlier in the program earlier this week. It is frightening how AI is going to be a game changer in this. What they explained to us is we're already there and you don't even know it. I don't know if anybody saw the announcement from the iPhone Apple folks yesterday. The stuff that we are going to be able to do in the next 1, 2, 3, 4 years is going to be game changing on that. We need to be having conversations now in healthcare about how that impacts, because there's parts of that that's so amazing and it'll be great. But it doesn't stop the need for some human intervention on parts of that. So I hear what you're saying. I think there's a lot more work to be done from the hospitals, government. Like, we got to get a crew together that starts to talk about this, because we're going to be holding on to the bumper here real quickly, because this is going to be exponentially but if we can find ways to get caregivers paid within homes to be able to care for the people they love, I think is going to be a big part of that as well. But I don't know how others feel.
No, I mean, that's basically, as far as the AI piece, we had a bill that died in the city in the last 2 weeks that was, basically set up a commission of folks who do research in the area and manage the environment state or regarding ways to get fires and get them to the AI is powerful. So the two last of the devices, the different devices that come out, the dangers of that are not all about it. And so we're looking at about and of course the governor set up some hopefully up here at the hub. But also trying to figure out how to do it. So we're looking at it and we're always
So during Fran's question, I was waving at Paul Verchinski on our HCCA board over there because I know something he's worked on in past years is trying to get the county to start back up a program they used to have where they did home health care visits. And they would help people to determine what kind of things they needed to implement in the home to help them age in place easier. And that's something we're working on to try to get that started back up again.
Lisa, can I ask a question? Okay.
And that is that there are several nonprofits in this county that are doing it. And our Office on Aging received a grant, and they will be having occupational therapists just by phone, where they will give you like paid if you have money, if you don't have money, it's free. And that was a grant that they received. There's another entity that got a grant, and Paul can tell you more about that because he's trying to force it to use the money. And the Business for Housing Facility is also going to be doing other and
Rebuilding.
That's right. They're going to be doing the same thing because of what is needed, because most seniors stay in their home and then fall. And we need to stop that. So there's Jim, go ahead.
So the Affordability Housing Trust Fund, which is county government money to go to the trust fund, has funded programs dealing with some of that. Such as occupational therapy, which is county government money to go to the trust fund, has funded programs to deal with that.
And they pay for the
occupational therapists going into your home and doing an assessment around fall prevention and
they pay for the improvement.
Yeah, so the second funding, that HUD money, almost all of the to the Office of Aging, where there's a major program now to build out a program. The challenge is they aspire to build almost all of the Office of Aging funding goes need-based, general population. That particular money will be need-based. They aspire to build an add-on program.
Did you want to add something, Terri?
Nominal fee for service, but to date, the funding goes for need-based.
Did you want to add something?
No, I was actually going to survey the crowd and ask them, what would they be willing to pay for?
That's very good. I want to pay for salary
if you've got some of these additional services, but I'll decide not to ask that question.
Okay, so last sign up is Marianne Mayer.
Very good.
She gone? Okay, so we have time to take maybe one, maybe two more if we don't have any raised hands from before.
Lisa, can I jump in with one?
Sorry, I was like, where's
saw
that
you
coming
looking
from?
around. I'm right here.
Jessica. Okay. Absolutely, thank you.
Just a quick comment, because the question about taxes, and we're talking about aging in place, and I wanted to raise one bill that I introduced this year that was not successful, but I'm hoping to bring back next year, and I just wanted to mention it, and hopefully if anyone thinks it's a good idea, we can talk about preparing for next year. But this was actually an idea that a former member of our Howard County Commission on Aging brought to me, because in Maryland we have a homestead property tax credit. So if you own your home and the value of your home is increasing, we cap the amount of the increase in the assessment. I see lots of nodding heads. This is a pretty well-informed crew. And in Howard County, that cap is 5%. Okay, but for households that depend primarily on Social Security income, you never see a COLA of 5%. Right. And so what the legislation would do is say, if the majority of the household income comes from Social Security, instead of a 5% cap, it would be capped at whatever the COLA is for that year. And so, I think because what happens is that folks are, as you know, if you're living predominantly on Social Security income and your assessment is going up 5% every year, but your COLA is consistently less than that, you fall farther and farther behind in terms of that compounding effect. So I just wanted to mention it. As I said, it's a bill that did not pass, but one that I'd like to try again. So happy to have any input from folks. Right.
Now, I'm sorry. I'm not saying I'm, low income that needs assistance, et cetera, but it's not.
So expanding from Social Security
I
look
really
at pensions
think,
as well.
Especially if you want support from this area, that federal retirees. One of the reasons my mom was convinced I should be a federal employee, do get a better pension, but it doesn't go up by that much.
So I think we have time for one more. There was a hand raised over here. Thank you.
Good evening. This is my first time out of my so many years living here in Howard County. Didn't realize this existed, so I'm kind of excited to hear everything. I had so many questions as I heard you all speak and bring up, but I want to kind of give you a little bit of my experience as it ties to health, as it ties to education, as it ties to, and she left, the crime. And to me, out of my years, I'm a transplant, didn't grow up here, moved here, and you mentioned something that just really resonated with me. You said that some of the health is tied to housing. And so in my experience here in Howard County, been to Howard County Hospital twice, to the emergency room. Back in early, I would say, the 90s, I was in and out in an hour. And I remember calling my brother back home. I just got out of the emergency room in an hour. I went 2 years ago and had to pack a lunch. So my whole issue that I've seen throughout Howard County, not just Columbia, is the too much development, if that makes sense. And I say that with love, in the sense of the community sense is gone. I hear that, thank God, I live next to a nurse who told me, don't go to the urgent care because what happened to you, you need to have a CAT scan. So I think education is lacking in this county, where when I first moved here, I was bombarded. Okay, all that's gone. Then to tie it back to the housing, you mentioned something that I'm not familiar with some of the rules as far as AFFLO.
I'll go over it again when you're done. Thank you.
I always, it is. I always tie it back home. When I moved here, I bought into the dream. Because of greed, and I'll just call it what it is, a lot of the dream has left. So you have some of the disparities that I'm even hearing from here. I moved to Tor when I first got here, so I'm like, what happened? So it's sad because I think the left hand's not talking to the right. And then I also heard a piece about how when some of the new developments coming in, because I saw them build River Hill, I saw them build Maple Lawn, and I didn't see affordable housing there. Now all of a sudden, we need all this affordable housing. You had the opportunity and you did not. So I think that as long as we are advocates to see the whole picture, again, Howard County is this big. And anybody will tell you, given the situation, I work in DC, and I've seen projects, because I'm old school, they build them up. That's what you're doing here in Howard County. That model does not work, period. But we're allowing it here. So I don't know what to say. It shows in the schools, and you concentrate. And I'll use that word. You make it a ghetto in one place. So until we get back to the community sense and educating people, I don't know what to say. And it's coming in, when she mentioned that, I was like, wow, is that what happened? I literally, in the ER, I'll never forget as long as I live. Coming from not the suburbs of Chicago, inner city, Cook County, spending all night in the ER versus coming to Howard County, spending an hour, and now 10 years later, because of all the development, I'm in there 8 hours. So I would just say I'm gonna try to get more people to come to this, because people complain, and I'll get to the property value, about their property value and housing, and I am a fan of the homestead, and I think it should not be tied to anything other than your age. I think why and out of all counties, I think this is a county that can have a model for that. You turn 65, your taxes are capped. Let's see how that works. So I really have enjoyed this.
Thank you. So does anyone on the panel want to address her comments before I go insane? Just kidding. Anyone? Okay, I do want to answer your question.
I just would like to say thank you for putting this on tonight. And,
You're very welcome.
Meghan, thank you for coming up from lovely downtown Elk Ridge. Okay, yay, Drew. We said it. And sharing your incredible information and yourself with us tonight. We really appreciate it.
Thank you, everyone. I do want to answer her question. Marianne, you brought up some great points. I just want to say that what you were referring to with your question is the Adequate Public Facilities Ordinance, APFO. It is a county ordinance that controls the speed with which developments can go into certain places that are considered to have constrained schools. Sometimes there are road projects that are planned. And I could talk all night about it, and I won't. But I do want to end with just a quick comment about, hey, we're almost done. that in the county you will see a lot of contention about we need to develop more. We need to develop more so that we have more supply so that housing prices go down. And then the flip side of that is we infrastructure advocates want affordable housing, but we want not fees in lieu paid because that concentrates it. We want more permanency of it. And we want to hold feet to the fire for getting benefits and fast passes to provide what they are saying they're going to provide. And so we hope we can balance those things, and we appreciate all of our legislative efforts in that regard, and we thank you for coming, and we thank Meghan McClelland for her time. It's been very informative, and thank you all for coming out. Thank you again to our board and everyone who helped put tonight on. Good night.